Hello guys, today let's talk about cervical cerclage. Now this is a very common thing that you will be encountering in your routine clinical practice where you will find patients who come with cerclage in situ. So it's very important for us to know when do you advise the patients, that is the indications, the contraindications, what are the methods which are used to put and what are the precautions you take and when should you deliver a patient with cervical cerclage. Let's learn more about it. The source I have used is the Studs Recent Advances textbook, and it has a chapter especially for the cervical cerclage. So I highly recommend all the residents to definitely go through this topic. Those who are new to this channel, hi, I'm Dr. Sonali Jagati, Senior Resident Obs&Gynae at SCB Medical College and Hospital, Cuttack, having secured an All India rank of 3546 in NEET PG 2021. So cervical cerclage is basically a stitch that is placed in the cervix, and it is the mainstay surgical treatment or the intervention for prevention of spontaneous preterm birth in women who are at risk for second trimester fetal loss and preterm birth. Remember, one of the important cause of second trimester loss is the cervical incompetency or cervical insufficiency. So for management of the cervical cerclage is one of the mainstay treatment. So now what are the different scenarios in which cervical cerclage is put? Basically, you can divide the indication for cervical cerclage into three types. One is history based, next is ultrasound based, and next is emergency cerclage. So what is history based? So also in the NEET PG or INICT, they ask you as a case based scenario. Let's look into all three of them individually. History based is when a woman who has a previous history of 3 or more recurrent spontaneous preterm birth, or that is 3 or more previous second trimester losses or preterm births less than 37 weeks, these have to be offered a history indicated cervical cerclage. Okay. Okay. Next comes the ultrasound based or ultrasound indicated cervical cerclage. So a woman with singleton pregnancy who is considered high risk for spontaneous preterm birth, that is, if she has any previous preterm birth or second trimester loss or previous cerclage, known uterine anomaly, or any history of trachelectomy, can be offered cervical screening by ultrasound every 2 to 4 weeks from 16 weeks onwards till 24 weeks of gestation. Now this is very important. From 16 weeks to 24 weeks, you will screen any female who you consider as a high risk female for preterm birth. And as I told you, these are the potential risk factors. And she should be undergoing ultrasound screening for cervical length assessment. And women who are at intermediate risk. Intermediate risk includes previous loop excision or cesarean section done at full dilatation. Even these are considered as intermediate risk for preterm labor, and they also should be undergoing cervical length assessment. And if the length is less than equal to 25 mm, then you are going to put a cerclage for them. In emergency cerclage, the patient has already gone into labor and you have bulging membranes. So in this case, when you are putting a cerclage, it is called as rescue or emergency cerclage. Now let's learn about the types of cerclage. Mainly there are two types of cerclage. One is the McDonald cerclage and other is the Schrodinger's cerclage. A McDonald cerclage is a low vaginal type of cerclage, whereas Schrodinger's is the high vaginal type of cerclage. McDonald cerclage is where we put our purse string suture over the cervix as high as possible. So basically, suppose we start at the 12 o'clock position and we start taking bites. Around 4 to 6 bites we will take, and finally put a knot over here and we will tightly close it, trying to make the diameter of the os to 5 to 10 mm. So this is your McDonald cerclage. Next is the Shirokko cerclage. Shirokko is difficult yet very good type of cerclage in which we are going as high as possible. So for this we are going to separate the bladder peritoneum, that is the bladder reflection over the cervix is separated. We put the cerclage and then again we resuture the bladder peritoneum over the stitch. So this is called as the Shirokko cerclage. Remember that these both cerclages are done in the transvaginal route. If someone has a previous failed vaginal cerclage, then we have to offer her transabdominal cerclage. For transabdominal cerclage, we can do it either by laparoscopy or by laparotomy. Obviously, laparoscopy is preferred over laparotomy because of less bleeding chance and lesser complications, lesser hospital stay. So in this again, via the laparoscopy, we are going to separate the bladder peritoneum, and then we are going to put the cerclage as high as possible, and then we are going to resuture the peritoneum and close it. Any patient who has undergone a transabdominal cerclage has to undergo a cesarean section delivery only. Also remember that this transabdominal cerclage is going to stay till she completes her childbearing. That means if she wants to conceive 2 children, then after her second pregnancy only you are going to remove it. Okay, this is such. So routine advice of bed rest is not really recommended because no guidelines or studies have found any additional benefit. But of course, strenuous activity should be avoided and the vagina should be kept clean. Routine. Now coming to the use of progesterones. Routinely, there are no guidelines which suggest any additional benefit of using progesterones along with the cerclage, but clinically or practically, we definitely see patients are advised on progesterones once they have put or they have undergone a cerclage for the prevention of preterm labor. So in twin gestation, remember that as such, the short cervix can be an indicator for preterm birth, but routinely giving cerclage for twins is not advisable by the guidelines. Twins, the cutoff for cervix should be less than 15 mm rather than the conventional 25 mm in singleton pregnancy. Now, what are the absolute contraindications to cerclage? First is when she's going into active preterm labor, any clinical evidence of chorioamnionitis, PPROM, active vaginal bleeding, evidence of any fetal compromise, lethal fetal defect, intrauterine death, and when you feel that follow-up care is not guaranteed and patient does not give consent. The suture that we use to put cerclage is either black silk, ethylene or muslin tape. Monofilament sutures are preferred over braided sutures, although the outcome does not differ in both the sutures, but in monofilament the risk for infections is less, so that is why it is more preferred. What are the risks in general risks in case of transvaginal cerclage? That is any cervical trauma which can lead to bleeding, cervical laceration if she goes into spontaneous labor with cervical cerclage in situ. Preterm cervical shortening can be there despite cerclage, and there can be even damage to bladder. And anytime she has PPROM, then she might have to shift to emergency cerclage, and at that time there is risk of infection with chorioamnionitis. Also in case of Shirokko cerclage, where we had separated the bladder, so at the time of removing the cerclage we need to administer regional anesthesia. Now, what is the ideal time to put cerclage? So ideally you should put it at 12 to 14 weeks, but we can go up to 18 to 22 weeks. Generally after 24 weeks it is not put. 18 to 22 weeks is very crucial because at that time you have already performed a TIFA scan. That is, you have ruled out any gross congenital anomaly or the lethal anomaly in the fetus. It's always advisable to do the TIFA scan before putting a cerclage or before advising any cerclage. Only after you have ruled out fetal anomalies, you are going to put the cerclage. In case of emergency cerclage, it is done by using a Foley's balloon catheter, where you are going to inflate the balloon, put the sutures, and then deflate and bring it back. Of course, there are risks of sudden rupture of membranes or of the bulging membranes. Always advise the patient about the risk and benefits that are associated with cerclage. Take her informed consent. Only after the patient gives the consent, you are supposed to perform the cerclage. Remember that cerclage is a very good tool for prevention of preterm labor, but in spite of putting cerclage, there can be preterm labor also. So this has to be clearly told to the patient and her. Coming to the mode of delivery, so if it's a transvaginal cerclage, you have to electively remove at 36 to 37 weeks to minimize the risk of rupture if she goes into spontaneous labor. If you are planning for an elective cesarean section, then you can definitely delay it and you can remove it during her C-section itself. So removal of a McDonald's cerclage is very simple, where you can just do a perspiculum examination and you can remove the low sutures. Of course, as I told, high cervical sutures or high cervical cerclage like Chirodkas need regional anesthesia. As again I have told, I'm re-emphasizing, anytime you have evidence of chorioamnionitis, that is she has leaking PPROM and active labor, active vaginal bleeding, or any other indication where you want to deliver her immediately, you have to remove the cerclage. In case of transabdominal cerclage, the mode of delivery is going to be by cesarean section only. Controversial question as to should you routinely screen all the women for their cervical length? Then the ACOG practice bulletin has also mentioned that a singleton pregnancy can be screened for cervical length from 18 to 22 weeks, even if she doesn't have any history of prior preterm birth, because although it does not give any additional benefit, but there is no harm in screening for cervical length. Remember, for the screening of cervical length, transvaginal ultrasound is preferred over transabdominal ultrasound, and this has to be done around 18 to 22 weeks for a singleton pregnancy with no prior history of spontaneous or preterm birth. And if she has a prior history of preterm birth, then you have to start screening from 16 weeks onwards. The cutoff is 25 mm, and vaginal supports can be given plus minus. So in a nutshell, if I have to tell you, which is commonly asked in your MCQ exam, so when do you offer her cerclage? So they'll give you a patient who has a history of prior preterm birth and the ultrasound is showing you less than 25 mm. So you definitely have to give her cervical cerclage. Now, if she doesn't have any history of prior preterm birth or recurrent pregnancy loss, and only the ultrasound you did a screening, and by incidentally you saw that the length is less than 25 mm, in this case you're only going to give her progesterone support. These two important points you have to remember, because these are frequently tested in your MCQ exams. So this is a nutshell about cervical cerclage. I highly recommend that you watch some of the videos that are given in the YouTube by so many senior obstetricians who have beautifully performed the cerclage surgeries. So once you know the theory, now when you watch the surgical videos, you will really understand it well. Any doubt, feel free to write in the comment section. I'll be glad to answer.